Okay, so BPH, this is now that I'm getting older and my patients are getting older, this is certainly something that I am now a stranger to. Here we're showing a guy that's, who knows how old he is. He's probably my age or so, but he's starting to look for the bathroom. So benign, meaning we're not talking about prostate cancer today. Prostatic, it's your prostate growing. Hyperplasia means growing. So let's kind of dive in. That's sort of a housekeeping item. I'll let you read that. I've already shown you this, so this is me. Um, and here we go. This is, first of all, I'll just kind of, we'll talk about an overview of what we're going to do here. But this is a common problem. This is becoming probably one of the most common things I'm dealing with now in my practice. So let's talk about number one. What's the prostate? Nobody usually knows what that is. They know it's trouble, but they're not really sure. So at the end of the talk, you'll know what that is. You'll know what does it mean to have BPH, or this ubiquitous problem of your prostate growing as you get older. It's part of life. And then how can we help you with it? So what is the prostate? So here is a side view of a man. And the bottom line is I talk about the prostate as being basically a junction valve. You do urinate through the middle of it. So you see here's the bladder, it holds urine, and then you have to urinate right through the middle of it, and then it goes out your penis, your urethra here. So you might imagine as the prostate grows as you get older, if you think of it like a donut, the hole just gets smaller and smaller and smaller, like a bathroom sink that's starting to get clogged slowly. If we talk about what is the prostate, I mean, it's a gland. That means it makes something. It makes a little bit of fluid that's in your semen, and we're not really sure what that does. But the way I describe to people, what is the prostate? Why is it there? It's pretty amazing that we're able to use the same pipe, which is called the urethra, for two different systems. We urinate through it and we ejaculate through it. So that miracle of using one pipe for both of those systems is accomplished by the prostate. It's like a junction valve where the structures that make semen and sperm plug in, and it's used for both systems. So it's not that it has much of a function, it's more of a junction. But the problem is it grows as you get older, and it starts at a young age. Now, so many times people will say, I have prostate. You don't know what that means. What does that mean? It means I have trouble with my prostate. But these are the three categories why urologists are kept so busy helping men as they get older with their prostate. So we're going to talk about this one in depth. Your prostate can get inflamed or infected, whole other discussion. Your prostate can get cancer, and whole other discussion. Something I know a lot about and certainly give a lot of talks on. But tonight we're going to talk about enlarged prostate. Not everyone gets prostate cancer. Not everyone gets prostatitis. Everyone to some degree will have their prostate grow and usually affect their urination negatively in some way. So it's a big problem, common problem, part of life. So we've already talked about this in a large way, so I can kind of skip through this. Why does enlarging your prostate cause trouble? Just think of the donut. It actually doesn't matter how big the donut is. It matters how big the hole is. So if the hole starts to get smaller and smaller and you have to urinate through it, the bladder has a hard time pushing urine through. And this is going to end up being, manifest as symptoms, which we'll talk about in a moment. Okay, I've tried to make it really clear already, but I want to really make it clear because most men, the first thing they're worried about when they notice they're getting up at night once or twice is they're wondering, or their partner, spouse is wondering, could that be a sign of prostate cancer? And very rarely urinary symptoms are a sign of prostate cancer. And so the most common visit when a person's maybe around 48, 49, when talking about this problem, is reassuring the patient this has nothing to do with cancer. Don't worry about that. They can be screened. We can do a PSA. Certainly, I have lectures on that on my website about PSA. But again, prostate cancer generally doesn't cause symptoms. enlarging prostate does. So usually reassurance is in order for a patient when they first come in saying, I'm noticing a change. This is just a schematic that says what we've already talked about. You know, if you have to urinate through your prostate here, you know, and it's actually wider than this, you can imagine if it's huge and this is getting smushed, this won't open up and it'll be hard for you to urinate. Okay. That's what they're showing you here. It's actually not well demonstrated. But the analogy I like to use in this circumstance, so let me see what the next slide is to see if I'm not hurting myself here. No, is I always use with patients in the office the analogy of a bathroom sink, not a kitchen sink. If that's clogged up, you have a problem. A bathroom sink, everyone knows that eventually their bathroom sink starts going a little bit slowly. You know, your spouse's hair may go down there, things go down there. And it's not rocket science. And we're going to get to that with treatment. It starts to go slowly. It doesn't drain well. Sometimes it even retains water and it takes a long time to go down. Same thing happens here. You retain urine eventually. Your bladder doesn't empty well, and you'll retain urine after you urinate. You don't completely empty your bladder as a function of being obstructed. But what are the other symptoms that happen? It's basically two things. You urinate slowly. No one usually complains about that, to be honest with you. What they complain about is getting up at night. That's what they complain about. They will complain about the fact that their bladder is now angry at them and will have an urgency to go. So when you're younger, you can hold it forever. It's no big deal. But when you're older, there tends to be this urgency to go because it's your bladder revolting on you, saying, I'm not liking how you're making me work so hard here. So these are all things that come along with being blocked, starting and stopping, can't urinate, that kind of thing. The thing that brings people in usually, though, is if they have this urgency, which is annoying, they're worried they're going to urinate on themselves, or if they're getting up at night. And that's what's starting to happen to me. This is just saying how ubiquitous this problem is, that, you know, that I usually say almost everybody have something. I don't entirely agree with this statement that enlarged prostate has to do with sexual problems. I'm aware of the study, though. Just recognize that this is saying it affects your life. If you have it, you know it starts to get annoying. And we'll talk about the threshold where that annoyance will drive treatment. And if we look at this question, who can get BPH? The answer is if you're a man. It's that simple. If you're a man and that means you have a prostate. Women don't have prostates. And eventually, you know, you go to a golf course and see a guy in his 80s, you're going to see a guy you're going to see men that are talking about their urination. So some of this is a little bit controversial, this statement, you know, being, you know, obesity and lack of exercise can increase the risk. But let's just say everybody has that problem. And, you know, how do we diagnose the problem? How do we know you have enlarged prostate? And just for a moment, since we're talking here about physical exam, let me differentiate between two things. There is the notion of having an enlarged prostate, and we call that BPH. Like pathologically, we say there's a change, your prostate's growing. And that might mean your rectal exam, your internist might say, you have an enlarged prostate, which doesn't mean much. We urologists are going to talk about enlarged prostate trouble with regards to the symptoms that you have, not necessarily how large your prostate is. Remember that you can have a huge prostate, but if the hole in the middle is big, you can have no symptoms at all. It does correlate generally how big your prostate is to how you urinate. And a very common thing is that an internist might mention during a rectal exam, some don't do them anymore, oh, you know, you have an enlarged prostate. And the patient leaves the office thinking you might be telling him something worrisome, that he may have prostate cancer. And I usually say you have a normal prostate, meaning I don't feel any trouble there. Prostates come in all different kinds of sizes. But the reality is that we talk now, and for the rest of our talk, we're going to talk about enlarged prostate, meaning you have symptoms. And we have surveys that will very much quantify the symptoms and make your visit with us very easy to tell us what you're trying to tell us. This is the most common one. Anyone in my office has seen this one, the IPSS survey. So We're talking about symptoms here. We talked about some that are annoying. Before we get into treatment options, well, let's see. No, this would be good. But I'd like to, let me talk before we talk about that slide, because that slide I have to rearrange a little bit in my talk because it's not perfectly arranged how I would do it. So generally, if someone's going to come see the urologist about urinary symptoms, it's generally 3 visits, and it tends to be progressive. The first visit, I've already mentioned, is a reassurance visit. It tends to be a visit where the patient is just worried that their symptoms might be from prostate cancer. They don't usually say that to me, but I know that's what they're thinking. So I usually throw it out there. This has nothing to do with it. You can get screened. We can do something called a PSA test. So there's the reassurance visit. And then the second visit tends to be, okay, you're reassured, but now you're annoyed and you've crossed a certain threshold. And anyone who's been in my office will hear me say, are you bothered to the degree that you want to be treated? And that's different than I notice a change. And the patient is the driver typically of when they want to be treated. There are certain medical situations where I'm going to say you must be treated. Things like you can't urinate at all, you're getting infections, you're getting stones, you're hurting your kidneys. But mostly this is a process driven by the patient. When they're ready, when they say they're bothered enough to try something, we'll try something. And that's going to be medicine with me first. This slide's going to talk about medicine or procedures, but I'm going to consider medicine the first line. And then there's the patient where medicine fails, and then they're going to say, what else do you have? And then I'm going to talk about second line. And then there's people that the second line treatments, which are procedures, don't work. And then we're going to talk about third line. So that's how I'm going to present this. Reassurance visit, I'm ready to be treated with a medicine. Medicine is not working well enough or not anymore. I'm ready to think about an office procedure. Office procedure didn't work or isn't working anymore. Or I have a medical complication. I'm ready to think about an operating room procedure. So I don't have a slide there. Wanted to get you thinking that way. And now let's dive into this slide. It talks about treatment. So we know what it is now. We know it's not, you don't have cancer. It's like part of getting older. That means you ache in the morning. That means you have gray hair. That means lots of things. It also means you start to urinate more and be annoyed by your prostate. So what's the first treatment option? Well, there's behavior modification. And you know, the first treatment option, as I told you, would be nothing, because you just need to understand that it's not cancer. But if you say, now I'm annoyed, I want to do something, there are patients that will say, well, I just don't drink anything after 6 o'clock, which is maybe not the best way to go. As somebody, I do triathlons, I work out a lot. When I'm getting close to a race, I'll work out like crazy, and I have to drink a lot. And I know if I work out late in the day and I'm drinking in the evening, I will be paying for that night. So I can commiserate with those patients. But that's one way that people try to address this. I'm not going to drink much. It's not a great long-term option. This really, you know, for people that have this urgency where they were worried they're going to urinate on themselves, this idea of bladder retraining or Kegel just means, you know, if you squeeze like you don't want to urinate, we all know, you know, if you have to urinate really badly, if you squeeze really hard, you'll get a reprieve from that feeling for a little bit. That's really what that is. That's not really a long-term play. Watchful waiting means you're just going to see if it gets worse. So I kind of put I'm reassuring you, you can do these little things that you want, but you haven't decided yet that you really want to dive in and be treated. And for a lot of men, this might be their first medication, their first pill that they're taking. So it's hard on them to decide that they want to do something like that. It's sort of, it's like a stepping stone in life sometimes. So anyway, that's usually how that's presented. And if the patient says, yes, I am bothered now to the degree that I want to be treated, then to me, the first line therapy is medications. We'll go into those. And we're going to go into these treatments, as I said. So this should say, you know, reassurance, first line medicine, second line, water vapor therapy, or permanent implants. We'll talk about the trade names there. And then third line, office or operating room procedures, which can include opening up the prostate with lasers, opening it up by shaving it out, opening it up by coring it out. But these are all operating room, things like that. So just keep thinking about this progression, because BPH is a progressive problem. If somebody sees me and they're 50 and they're wanting to be reassured, they're going to probably get to the point where they say, I want treatment. And if they're on medicine, they're going to probably get to the point where that's not making them happy and they're going to want something else. So that's the way I'd like to present this, as a progressive problem. And, you know, this is a strong statement, but this is a big part of our reality, that when people are in this mode, behavior modification, this mode here of I'm going to do everything I can to not start a medicine, should also include alternative remedies or, you know, herbal treatments. It's probably where it should go. I think, you know, Boston Scientific's trying to point out here that the herbal medications in general, I know a fair amount about this because my mother used to be the special assistant to the director of the Institute of Alternative Medicine. Generally, the herbal remedies and things on the shelf at GNC have not been shown to work more than placebo or sugar pill. If they did work better than sugar pill, the drug companies would patent them and make a lot of money off of them. But when patients are taking the super beta prostate, or, you know, that used to be a very much advertised by Joe Theismann around here, or other herbal preparations in a pill, I don't necessarily say you can't take those. That's just the same as saying you're going to do behavior modification, you're going to try something else if it works for you, even if it's placebo. If you're happy, I'm happy. But to ask whether they're shown to work well is a different story. These are all ways, to me, of this is what you can do before you start diving into actual treatments. So we've already talked about this. This is basically saying, no, I'm not bothered to the degree that I want to be treated yet. Now, alpha blockers, we should talk about that, because that is the workhorse. Those are the mainstay medicines. Those are the main medicines we're going to use to try to help you. Trade names would be Flomax, Uroxetrol. There's a newer one that most people don't use anymore called Rapaflo. Flomax is generically called tamsulosin, and Uroxetrol is called oh, it escapes me right now, but so these are the alpha blockers. Psilocybin is Rapaflo, and the bottom line is that these medications are, what do they do? They're once a day. They're very easy to take. They are the ones that are known and will show themselves to work better than sugar pill to help your urinary symptoms. What are they trying to do? They're trying to relax. Remember that anatomic drawing where you had the bladder and the prostate? Well, there's little smooth muscle fibers in there. So it's trying to relax those so that when your body does try to urinate, it just does it, it relaxes a little more, it opens it up a little more, and helps you urinate more freely. The results don't tend to be dramatic. I usually describe these medications as they ameliorate the symptoms. They don't solve the symptoms, but if you can take a person that says, I'm annoyed, to, well, I still have an issue, but I'm not that annoyed, well, then it's a reasonable solution. For me, it's the safest thing to do. It's for me always the thing to start. I always question when I hear someone has seen a urologist who went straight to a procedure. I at least want to know if these medications would work. I want to let the patient take them for a month or so, because I want them to make the decision. That's not good enough for me. Often one of the side effects that's notorious with Rapaflo or with Flomax is it can cause you not to ejaculate temporarily, and that's not a fun thing for people. That's why we use Uroxetrol. It's called alfuzosin generically, but I was blocking on that. That's the one that has the fewest of that side effect. That's why I use it. Flomax can have a bit of a drop in blood pressure. There can be some side effects, but they're generally very well tolerated, except for the ejaculatory dysfunction for all those except for alfuzosin. So to me, this is just the world according to me. To me, Everyone should try these medications. They can say it worked great, but I don't want to take a medication the rest of my life. I would prefer to be fixed with an office procedure. And I think that's reasonable. But my own opinion, this is my opinion, patients should be exposed to the medicines and then make a decision. I always say, if you're not happy in a month, come back, we'll talk about the next step as a progressive issue. So those are alpha blockers, different ones on the market. There's even whole older ones that have more side effects. Hitrin and terazosin or Hitrin and Cardura are the trade names, but nobody really uses those anymore. Here's another class of medications that are used. Now, these were the original ones, the original medication that came out. It was a blockbuster. No one was ever gonna have a procedure again. Was called Prostate, and that generically is called finasteride. It has a competitor called Avodart, which is called dutasteride. But what do these do? They actually will shrink benign prostate tissue. They will shrink benign prostate tissue. So if you think about it, it sounds like a great idea. If the problem here is that your prostate has grown and we have a medicine that will shrink your prostate by 50%, it sounded like a perfect plan. Problem is it shrinks the donut, but it doesn't open the hole. So some very big studies were compared between these drugs and the alpha blockers, and it really then exposed that these drugs didn't work any better than sugar pill. And that's when Merck, the company that was making Proscar, started marketing it for hair loss. Finasteride is actually Propecia for hair loss. Some of you may have heard of that. So these are not the mainstay medications I think that a urologist is going to use. Merck spent a lot of money to try to salvage its reputation to show that these drugs did work. They are probably the way to go if somebody has a huge prostate, an enormous prostate. And some people do. We'll talk about that later. It's been shown to help those people and keep those people from getting to the place where they can't urinate at all. But generally, it's going to be alpha blockers. And if an alpha blocker is not working well and the patient says, well, I'm not willing to move on to an office procedure, I'm just not willing, well, then there's nothing else to offer that patient other than one of these drugs. So why not? So you'll get patients on more than one drug, maybe one drug or even two drugs. It's really, I can tell you, it's a practice pattern issue. If you're seeing a doctor like myself who does a lot of these office procedures, you're going to find very few patients in my practice that are on two drugs, because I'm going to offer the patient an office procedure after the alpha blocker fails. I'm going to have them watch my webinar. I'm going to have them look it up on my website. And they're going to learn. My patients don't have fear of the unknown. And generally, people will try an office procedure if they're not happy with the alpha blocker, because the efficacy that they're going to get from the finasteride or the dutasteride isn't going to add much. But it is what we do when you're not willing to do anything else. They do have some side effects that are worse and more troubling than the alpha blockers. They can be causing erectile dysfunction. They very commonly make it so you don't shoot much semen. There's even something called Proscar syndrome, which is very controversial. But just knowing, to me, the added side effects and everything else that go with this, I'm usually leaning more towards helping my patients with an office procedure if an alpha blocker fails. But know that there is a second class of drugs out there. So now we're going to talk about treatments. Remember the progression. So if you're very happy with medicines, and everyone's heard me say this a million times in my office, if you're happy, I'm happy. I'm only going to tell you to do something different if you're hurting yourself. And sometimes that hurting yourself is you're retaining urine, you're stretching your bladder out, you're making it so down the line your bladder won't work well. I'm going to maybe nudge you a little bit to do something about it. And we talked about those other medical concerns where I'm going to tell you really need to do something. And I can tell you, if you're hurting your kidneys, or if you keep having infections, or if you're having stones and all these other problems, we're probably not going to talk about an office procedure. We're going to talk about an operating room procedure. They're not that bad, but that's what we're going to talk about if you have a medical problem. But if we're just talking about the guy who first wanted reassurance, then he was annoyed and took a medicine, Now he's annoyed on medicine. We're going to, generally in my practice, we're going to offer an office procedure. Office procedure. So why am I calling them office procedures? I call them office procedures because they can be done in the office. Certainly right now, at least, I'm about to build a new office in my Chevy Chase area. And it's still the same thing. It's an office. These days, the medical economics are such that commonly urologists will be part of major big groups, and it's much more lucrative to do everything in a surgery center. So things are done in surgery centers or through the sleep. But these treatments that I'm about to tell you about, they are designed to be very quick, easy things done under local anesthesia in the office. So this one's called water vapor therapy. This is sort of the slide deck that doesn't use trade names. Water vapor therapy's trade name, which is the Boston Scientific product, is called Rezum. Rezum, R-E-Z-U-M. Before Rezum, I did its predecessor called TUNA, transurethral needle ablation. And I went for a long period of time. I did many of those. It's the same idea. Water vapor therapy and TUNA are both treatments that are not going to cut anything. They are going to sink needles through, from the donut hole into the meat of the donut or the prostate, and they're going to generate heat. The TUNA did it by vibrating two needles imperceptibly and then creating a little defect where the tissue was devitalized. The Rezum is also creating heat, but it's dripping water through the needle such that it creates steam. And the advantage of that is it spreads out more. The hope is that it works better and it's more efficacious, and it is much faster than the TUNA. So I switched over. I originally tried the Rezum. I really wasn't, I was trying to numb people the same exact way as I did with the TUNA. And I found that it hurt more. It was much more acutely painful for the patients, and I didn't like that. And I also found that it was a little harder for patients to urinate after the Rezum. And so I kind of went back to the TUNA. Then I kind of went back to the Rezum, and largely because the TUNA is so old that it's just not out there on the internet much. Some of the insurances were starting to say it was even experimental because they hadn't heard of it. And that really forced me to really give Rezum a much harder look. And I created my own way of numbing patients such that now it went from it hurt more than the TUNA to it's less painful. Patients hardly feel anything now with me. And now that I've done hundreds of these now, and I understand how to counsel the patient through. I still we'll talk about how this is done, but I still do it like a TUNA in that I only keep a catheter in for 2 days. But sometimes I manage people's expectations about their urination better, and sometimes we get people to self-catheterize to keep them out of trouble. So things have evolved where this is the clear winner now. I actually also think it works better than the TUNA. But let's see if there are any slides. No. So there are no movies on this. So let's just talk very briefly. It's in great detail on my website at dcurology.net. But let's just talk briefly about how this is done. Patient comes into my office. They maybe have taken a Valium. They're offered that. Some do, some don't. The Valium is just so you're not nervous. Patients will all have had me look in with a scope already, so they already know it's not torture. I will numb their prostate through an ultrasound that goes up in their rectum. And then we usually do this as a sort of a tag team process between myself and my staff. They'll position you, and then I look in with a scope with the special device that's called the Rezum. And I do certain number of treatments. I put the needle in certain places. It's usually about 5 or 6, but each treatment is only 9 seconds. So the whole procedure, it literally takes about a minute or 2. It'll be very hard to urinate. I'm not doing this on patients that have an easy time urinating. So we have to put a catheter in at first just to give you a break so that you don't have to try to urinate. Patients take that catheter out generally early Friday morning. I do it on a Tuesday. Then they come in and see us to make sure they can urinate. If there's any trouble, we take care of them. And then there's no recovery after that whatsoever. Just stay on your medicines. It's going to take a month or 2 to work. You come back in 3 months and we see if it worked. It's a little bit dependent on your anatomy, but generally it's got about an 83% success rate. When it does work, it's a much higher bar than with medicine. When it does work, the patient's now going to say, I don't have any problem. I don't consider urination an issue. I'm off medication. It tends to be more of a home run than a single that you would get with medication. So that's it in a nutshell. There's very little downside to Resume. Infections are extremely rare. Blood in the urine can happen, but it's sort of just because I'm putting needles in there. But it can be a little harder to urinate at first. And there's about a 20% chance, though, this is the main thing people need to know, there's about a 20% chance that you'll ejaculate less semen. It's not 100% like some of the operating room procedures, but it's 20%. So that's something that I say, look, you'll have to decide if that's a major risk for you. You'll have to decide if you didn't have a urination problem at all anymore and I got you off medicine, but you had an orgasm, had an erection, but you couldn't ejaculate the same amount of semen as before, would you still be glad you did it? I usually bring that up. So that's Resume. I do a lot of those, and I'm sure I will in the future. But the other office procedure that is worth mentioning and used to be very, very heavily marketed, and it's not as marketed anymore. It used to have TV commercials. And I think there was a lot of fanfare, and it was adopted by a lot of urologists. It tends to be quite lucrative. Is prostate urethral lift, otherwise known as UroLift. UroLift, and maybe you've heard of that. Most have heard of that well before they've heard of a Resume. Generally, you're going to not find a urologist that does both. They're either going to do UroLift or they're going to do Resume. I think the tide is turning, and I think it's changing a little bit. As much of the original fanfare with UroLift, I think people are oftentimes not having great results with that. But I would say more urologists, at least within the last 2 years, do UroLift than Resume. But I don't do UroLift. I can do UroLift. If somebody says, I really want you to do it, it's fine. I think it has two things going for it. It has two marketing points. And I don't usually find it to be an issue in my practice. The one marketing point, so what is it? So I've said that a Resume is we're not cutting anything. We're putting needles into the prostate and we're heating the tissue so that it withers away over the next couple months and opens up the donut hole. What the UroLift is I always call it the Batman grappling hook. I'm assuming anyone on here is old enough to know what that is. Where Batman and Robin would throw a hook up and then climb up the building. So what this is firing sutures out the side of the prostate and outside of it, and it kind of opens and then pulling on them so that it mechanically pulls your urethra open. The advantage, there are three advantages of that if it works well. Number one is theoretically, that means they don't leave a catheter in you, although I just don't find leaving a catheter to be any big deal for the patient. But I think patients have fear of the unknown. So as a marketing standpoint, it sounds like it's so important not to have a catheter. And it's not 100%. It's probably 70% don't need a catheter after this. It's a more immediate result. I don't find that to be so important because generally patients have lived with this for years. So waiting another 6 weeks or so for the Resume to work just doesn't seem tantamount to a big deal. And the most important marketing point that the makers of UroLift bring up is generally it does not affect your ejaculatory volume. So it tries to market itself very much as a first line. Its whole marketing plan is to present to the patient much what that other slide did, which was, hey, we're going to offer you this. You can do medicine or you can do a UroLift. That's kind of how that's supposed to be addressed. And I don't agree with that marketing plan. The main reason I like those benefits of the UroLift, but the huge downside to the UroLift is I've seen a lot of patients who are very unhappy with them, didn't work, and the sutures were put into the wrong places. So that's one thing I don't like. I just don't see that with Resume. The second thing I don't like is that Resume has very few complications. It's not much bad can happen. That's why we try it very liberally. But UroLift carries with it the risk of when you shoot those sutures through, we surgeons that do prostatectomies for cancer know there's lots of big veins around there. And you can spear one of those veins and then end up with a big pelvic hematoma and end up in the hospital. So that's just not what I'm looking for in an office procedure. I'm looking for something that's very low risk. And then the third thing that is the main reason I don't really like the idea of UroLift is that it's leaving foreign bodies in your prostate permanently. And those can get infected. That's something that we urologists are training from day one to try never to leave foreign bodies there because of the troubles that it leaves. So it's just, for me, I find Rezum to be a far better alternative to try to not have foreign bodies left, not end up with the potential of a hospital kind of complication. And I just, in terms of the ejaculatory volume, by the time I see a patient who wants this, they're usually already on these alpha blockers. They already kind of have that complaint to some degree. So I just haven't found that to be a huge deal breaker in my practice. So these marketing points don't usually ring so true in my practice, at least. Okay. And those are the office procedures. The tuna, which I don't do anymore and you won't find much. It's really Rezum or UroLift. I'm a big fan of Rezum. And now we're going to move on to operating room procedures. Operating room procedures. What does that mean to me? That means a procedure that you need to be asleep for, and a procedure that sometimes you have to be admitted overnight to the hospital for. So that's a whole other level of involvement. Now you need anesthesia. Now you have to get cleared for anesthesia. And now there's some higher risks involved. So what's involved and what is, what are the common side effects, or what is a ubiquitous side effect of operating room procedures? There's like a 1% chance, there's about a 1% chance, maybe a little less, of incontinence. So whereas we can never guarantee anything with office procedures, I've never seen anyone incontinent or heard of that. But it is something you can see once you start getting into procedures that are actually cutting out tissue or burning out tissue. So that's a higher risk, higher reward. Generally, office procedures work a little better. We talked about an 83% success rate. It's probably similar with UroLift, with the office procedures. Operating room procedures are going to be higher than 90%, but they have some risk. Much fanfare has been created. There's different lasers, by the way, so let's talk about them. Super marketed for a long time was something called a green light laser. That's before a lot of office procedures were out, and that was presented as a minimally invasive way to open up your prostate. At the time, we were doing something called a TURP. I'll get to that. We always kept people overnight for that. And a green light laser was something that you could go home the same day, and it could be done in a surgery center. So it was people who own surgery centers liked it. Patients like not staying in the hospital overnight. It has the same risks as the more aggressive procedures, but it doesn't work as well, at least not in my hands. The office procedures, the operating room procedures are generally going to make it so you don't have semen, period. So whereas I said there's a 20% chance of less semen with a Rezum, if you do an operating room procedure, all the ones I'm about to tell you, you're not going to have semen at all. So it's no semen and risk of incontinence. So that's why I tend to reserve these for people who are not doing well with office procedures. But laser therapy, the most common one is called a green light, and there have been other lasers around called Revelix and different ones. And what they do is they're basically firing the laser and burning the prostate tissue at such a high heat that it just vaporizes it. The problem is that the surface of that donut hole starts to lose its water and dry out, and then it won't penetrate at all. So it's not going to open you up like the other operating room procedures that we're talking about. It's easier to do, and younger urologists generally don't know how to do the more shaving out procedures as well as older guys like me. So it's something that a lot of people can do, and it's easy to do. But in my hands, I don't generally favor the laser procedures like a green light laser, which is also a Boston Scientific product. There's something called a HOLEP. So there's a holmium laser that generally is used for big prostates. We'll talk about that. I'm not sure if there's a slide on big prostates, but we'll talk about that in a minute. So I am a big fan of that. I don't do it, but I'm a fan of that. We'll talk about that. But So generally know that lasers are still operating room procedures. They have all the downsides of the things that work better. And what works better is this operation. This is the gold standard. It's called a TURP, transurethral resection of the prostate, and otherwise known as a roto-rooter, because here you're going to look into that donut hole and you're going to use a device that looks like this. I call it, in the old days, if you had a wine and cheese party, you'd have a block of cheese and we would shave off the cheese off the top. Doesn't seem to be in vogue anymore. This is sort of an electronic version of that, where we're going to shave off strips of prostate tissue until we eventually core out your prostate. That's going to be an immediate result. Half the time I keep people in the hospital overnight. I'm starting to send people home after this. Same side effects we talked about. It's an operating room procedure. But in my hands, certainly it works much better than a laser procedure. So I usually, if we get to the operating room, I'm normally offering you a TURP. It's not very painful. And it has about a 96% success rate. And you might say, well, why doesn't everyone get a TURP? They tend to hear the incontinence and the no orgasm, and they say, why don't we try the office procedure first? So it's very rare for me to find someone that wants to jump straight to this. There are exceptions. And remember, the medical problems that we discussed, they're generally going to get a TURP. Okay. And then here we have the term prostatectomy. Okay, there's nothing else there. So let's pretend this slide said, what do you do if you have a really big prostate? Another way to ask that is everyone a candidate for a TURP? Is everyone a candidate for an office procedure? Generally, there's certain anatomies. Big prostates are not great for office procedures. Decently big prostates are good candidates for TURP. Huge prostates are not good candidates for TURP. So it's smaller prostate is good for office procedure. Medium size is better for TURP. Let's just simplify that. But when you have a really big prostate, the safest thing to do is, instead of shaving out the tissue, it's actually to core it out. It's like a benign tumor, really, and it separates from the outer, I call it like an orange, a navel orange, where you could shell out the pulp and leave the rind. That's what a simple prostatectomy is. So don't confuse this with surgery for cancer. A simple prostatectomy cores out the middle of the prostate. In my hands, that's called a robotic simple prostatectomy, because I do robotic surgery. The competing procedure is that HoLEP laser that we were talking about. And so if somebody is seeing a doctor that's really good at either HoLEP or robotic prostatectomy, they never are good at both. They choose one skill set. There's really a pros and cons. There's no clear winner, but just know that there's a different menu offering if you have a huge prostate, and it needs to be an operating room procedure. Just 2 seconds about insurance coverage. I've never seen any of these things not covered. All the things we've described here generally are all covered. This is a medical problem that's not considered. It is your choice as to when you want to be treated, but it's still considered a problem that treatment is reasonable and not an elective thing to do. So you don't have to worry that it won't get covered by insurance. And again, this is not a great summary slide, because it should say treatment options, reassurance and watchful waiting. First line therapy, in my hands, in my opinion, should be medicines. Second line should be office procedures, which is Resume or Urolift. And then third line should be surgical procedures, green light, maybe in certain circumstances. TURP is the mainstay. Simple prostatectomy or HoLEP if you have a huge prostate. Okay, I'm a phone call away. Happy to talk to any of you guys about this. I really do encourage the next step, if you wanted to learn more, to go to my website and learn more. And we'll go through, these are just references to create these slides, so you can look at those quickly. But with that, this would end the